Welcome to 101 Nursing Tips. My name is David Woodruff, and I am the president of Ed for Nurses, where we empower nurses to become extraordinary. On this tip, I'd like to speak with you about DIC. That's disseminated intravascular coagulation. This is a concept that I found that many nurses have difficulty with. Join me for this tip to help you to better understand what DIC is, how we find it, and then how we treat it.
DIC is a condition that is caused by an out-of-control inflammatory response. There is an initiating factor such as sepsis, major trauma, bleeding, or abruptoplacenta that starts this inflammatory response. So if you're looking for a patient who has DIC or might be developing DIC, be looking for these etiologies. Now let's talk about one of these that you're probably a little bit more familiar with, the patient who is septic. So you have a patient admitted to your floor today with sepsis. What can happen in that patient is that we get either inflammatory mediators or bacteria into the bloodstream, and that causes an overwhelming, out-of-control inflammatory response. This overwhelming inflammatory response we call the systemic inflammatory response syndrome, or short terms, it would be SIRS. Now, inflammation causes three things to happen in the body. It causes capillary permeability, it causes vasodilation, and it causes clotting. Now, clotting is the part here that's going to lead to DIC. So we have an initiating factor, one of these things listed here, sepsis, major trauma, bleeding, or abruptoplacenta, which is causing this inflammation. Inflammation then causes the patient to have clotting. So let's move down to the capillary level here and take a look at what's happening. On the left-hand side of your screen, we have those initiating factors that are causing clotting. In the capillary network, we've got all these little microclots that are occurring. Now, then, you can kind of simplify this a little bit and simplistically think about it as being clotting on the arterial side and bleeding on the venous side. We have clotting occurring over on the left-hand side of our screen because of those initiating factors that are initiating inflammation. On the right-hand side of the screen, the tissue is sensing that there's clots and that we need to break them down. So it stimulates the fibrolytic pathway to break down clots. In addition, platelets are being used up to form those clots, and the patient will have a decrease in platelet count. It is this decrease in platelet count and also the initiation of the fibrolytic pathway that leads to the patient developing the symptoms of bleeding. So we have both clotting and bleeding happening at the same time. I hope that looking at this picture will help you to be able to understand better why we can have both situations occurring in the same patient at the same time. Clotting is occurring because of that initiating factor. Bleeding is occurring, well, because of the clots. So what do we look for in our patient? We look for bleeding, and here in the picture we've got a patient who has petechiae and some frank bruising. So these are obviously some frank signs that the patient has bleeding. We may also see other signs of frank bleeding, like blood coming out of the Foley catheter, out of the endotracheal tube, or nasogastric tube, or even oozing around IV sites. We may have occult bleeding that you're not seeing, and internal. So check that patient's H&H. The other part of DIC, though, that isn't as obvious, because you can't see it from outside, is going to be the clotting. And a patient can have clotting going on, causing venous thromboemboli, myocardial infarction, pulmonary embolism, strokes. All these things could be happening, and we don't see it from the outside. A patient who is developing signs and symptoms of DIC and develops a change in mental status could very well be having a stroke. We need to be assessing for these things, because it's those clotting, all those little microclots that are occurring in the capillary networks that can lead to ischemia and organ dysfunction. Now, diagnostically, we like to look at a number of different tests. Our platelet count is going to be decreasing as we use up platelets forming all these little microclots. The PT-PTT will start to rise as the patient is having difficulty with their clotting. Fibrin degradation products, also called fibrin split products, are going to increase because we have that stimulation of the fibrolytic pathway, which is breaking down clots. For the same reason, D-dimer will increase. D-dimer is one of the first things that gets elevated or released during the fibrolytic pathway. Fibrinolysis is breaking down clots. We have the clots forming because of inflammation, and then the body's breaking them down. So D-dimer in fibrin degradation products, also called fibrin split products, these things are signs that the body is breaking down the clots that are being formed by this DIC process. In addition, liver function tests can be elevated because all this junk is going back down to the liver and having to try to be filtered out. Now, how we treat DIC primarily is going to be to replace the blood products. The patient is losing platelets and clotting factors. So those are going to be two major priorities in this patient. Even though the patient may be bleeding from every orifice, the primary things we want to replace are going to be platelets, FFP cryo. We want to replace those clotting factors. If we're able to treat the underlying disorder, we can simply replace the blood products and the patient will probably do well. Now, in many cases in the hospital, we never even see a diagnosis of DIC because we're already doing this. You have a patient who's septic and the patient develops a low platelet count. Don't we give the patient platelets? Well, of course. You see, we're already treating this without even calling it DIC. However, in patients where we're unable to treat the underlying disorder, say, for example, your patient may have a viral sepsis or something like that, and we're unable to treat the underlying disorder, that's where heparin comes in. From our previous diagram showing the capillary network, now wouldn't it make sense that heparin may be helpful? Because if heparin stops the initial clot, then we won't have the rest of the system occurring. I know it's confusing when you see a patient who's bleeding from every orifice and the physician orders heparin. However, it is the heparin that helps to prevent the initial clot, which then prevents the stimulation of the fibrolytic pathway and the using up of platelets, which then causes the bleeding. So at least theoretically, heparin would be helpful. However, there aren't any studies out there that prove that heparin is beneficial and improves mortality in patients with DIC. But anticipate that your physician may order heparin in a patient where we're unable to treat the underlying disorder that is causing the patient's DIC. Otherwise, anticipate blood product replacement, starting with platelets, FFP cryo, our clotting factors first. Thank you for joining me for 101 nursing tips. If you'd like to get more tips, either by the web, by email, or by podcast, check us out online. It's 101-nursing-tips.com. Thank you for joining me. My name is David Woodruff, and until next time, bye now.